Hi, everyone. My name is Sasha Eisenstein. We're pleased that you could all join us for this week's lecture in Volume 9 of the KnowNeuropsychology Didactic Series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the KnowNeuropsychology Board, as well as members of the KnowNeuropsychology Committee. Before we start our lecture, one of the main goals of KnowNeuropsychology is to provide free, high-quality didactic content to our audience. Every KnowNeuropsychology lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get first access to new content. New to KnowNeuropsychology is our collaboration with APSIN to bring you learning and discussion questions that are provided with specific lectures content. You can access these on our website and through APSIN. Here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now it's my pleasure to introduce Dr. Dylan Wendt for today's lecture entitled Medication Options for Behavioral Symptoms of Dementia. Dr. Wendt has been the director of Cleveland Clinic Lou Ruvo Center for Brain Health in Nevada since 2021. He earned his undergraduate and medical degrees at Stanford University and the University of Miami. His postgraduate training includes residencies in neurology and psychiatry, a research fellowship, a deep brain stimulation fellowship at the University of Florida, and an integrated neuroimaging fellowship at the National Institutes of Health. As a faculty member at Emory University, he developed a clinical, research, and educational unit dedicated to optimizing the understanding, diagnosis, and treatment of behavioral problems in patients with neurologic illnesses. Since 2010, Dr. Wendt has directed the education department at Cleveland Clinic Lou Ruvo Center for Brain Health. The department provides learning and mentorship opportunities for K through 12, college, and professional students, has started 4 fellowship programs, offers educational programs for patients and caregivers, and the general community, and presents multiple interdisciplinary continuing education programs for medical professionals. Thank you for being with us today, Dr. Wendt. Now I'll turn it over to you.
Thanks very much. So let me share my screen. Want to make sure is the screen showing or are my slides showing, I mean?
I think it's about to. Yep, there we go.
Okay, great. Well, thanks for having me. And so today I'm going to talk about medication options for behavioral symptoms of dementia. We talk a lot about these options, but it turns out that there are not that many that are really validated, and certainly not many that are approved by the FDA. So my disclosures today, some research funding, none of which is actually relevant to this talk. And I'm going to give some caveats right at the beginning. One is that it's kind of difficult to be comprehensive when talking about behavioral symptoms in dementia, because there are so many different forms of dementia, and the behavioral symptoms actually differ substantially among these different forms. And that's not to say that there are any forms of dementia where you can't expect to see a particular behavioral symptom, but the likelihood of a particular symptom showing up varies quite a bit depending on the type of dementia we're talking about. And then, of course, we are putting both the syndrome of the dementia as well as the behavioral syndrome on top of a brain that is different from any other brain that's ever existed or ever will. So there are lots of individual quirks that occur in people's behaviors. And that's not to mention the specific environment that they may be in when the behaviors are exhibited. And all of these interact to cause very specific manifestations of behavior in a given individual, in a given context. It's also difficult to be definitive or dogmatic about what we say about managing behavioral symptoms, because the data are actually fairly limited. Although this is a problem that we know is extremely common in dementia, treatment, especially with medications, has not been studied as well as we would expect or hope. It's more common to find disagreement among results than concordance, and there are very few FDA-approved treatments for, for behavioral symptoms in dementia. So looking at one example of dementia, the most common form of dementia, Alzheimer's disease, we can see that there are a number of behavioral syndromes that can present. And I just want to point out a couple of things on this in the next slide. One is that even with folks who are relatively mildly affected, so in this graph, each cluster of 3 bars goes from mild to moderate to severe dementia based on MMSE scores. And then it shows how frequent or how prevalent the behavior is occurring in that stage of dementia. Even with the even in early stages of dementia, so those are the yellow bars, you can see that the frequency, the prevalence of these behaviors is pretty high. Really, a minimum of about 20% of patients are experiencing those behaviors. And this includes both what might be considered the milder behaviors, as well as even more disruptive behaviors. So even hallucinations and delusions in individuals with mild AD dementia are occurring at 20% rate. And the second feature is that you can see that in general, as the dementia becomes more severe, we see more people experiencing the particular behavioral syndrome. And then finally, all of these behaviors add up to more than 100%, right? So if you go across even in the mild dementias and look at the prevalences, that's going to add up to way more than 100%. Obviously, what that tells us is that the general rule is to see multiple behaviors in an individual rather than seeing just one. And of course, these behavioral syndromes have lots of consequences, all of which end up increasing the degree of functional impairment and cognitive impairment, as well as increasing the likelihood of institutionalization, hospitalization, caregiver burden, and reduced caregiver quality of life, as well as patient and caregiver distress. In general, although I'm talking about medication approaches, non-pharmacologic approaches are preferred when it's possible and when the situation warrants. And when I say when possible, I mean if someone's safety is at risk, then sometimes because of their more rapid onset of action, a medication is preferred. There are certain pharmacologic effects that we try to avoid. So in particular, blockade of cholinergic and dopaminergic receptors, or medication activities that reduce cholinergic or dopaminergic activities, can be harmful to cognition, primarily with the anticholinergic activities, or to movement and balance, particularly with antidopaminergic activities. And then we want to reduce the level, we want to avoid sedation if possible, because sedation, of course, reduces someone's ability to function cognitively as well as they might otherwise, also increases the risk of falling and other accidental injuries. The primary goal of treatment with medications is to enhance the safety of the individual and of concern, as well as those around them. So very often we find ourselves having to address behavior because it's dangerous to the individuals around the person with dementia, even though that person with dementia may not be necessarily endangering themselves. The second goal is to optimize the patient's quality of life. And third, to preserve maximal function. So we want people to feel and function as well as possible, but safety is the foundation, the foundational principle. I'm just going to quickly run through some non-pharmacologic treatments because, as I mentioned, we do want to try those first if we can. Psychoeducation for patients and caregivers is often recommended as an intervention to reduce the impact of these behaviors. Changes in the environment. Sometimes an environment is overly stimulating and can induce agitation or exacerbate anxiety. Changing that individual's activities. What's their schedule like? What are they doing in particular? Engaging them in more productive activities to reduce their likelihood of engaging in harmful emotions and behaviors. Aromatherapy and music therapy also have their place. It's really, really important to remember that many individuals with dementia are experiencing pain and unable to express it, or I should say, unable to express it in ways that we understand. So it's very important to pay attention to the potential for pain. And herbal medicines have been shown to have some effect. So that's ginkgo biloba primarily. Now, in terms of pharmacologic treatments, I'm going to go through um, a few blocks here. First, I'll talk about FDA-indicated medications. So these are medicines that have FDA indications for the purpose of treating behavioral symptoms in people with dementia or behavioral symptoms that commonly occur in people with dementia. And then evidence-based repurposing. So these are medicines that have been shown to benefit individuals with dementia with behavioral conditions, although they may not have an FDA indication. And then a little bit about the future and what we're looking at in terms of potential treatments to come. So FDA indicated one medicine is brexpiprazole. This is a medicine that is classified as an antipsychotic, more specifically an atypical antipsychotic. And the FDA indication is for agitation associated with dementia due to Alzheimer's disease. I'm going to make a small point here that the FDA currently permits you to get an indication for a specific diagnosis. And this becomes important later when we talk about a different medication. So that's why, as opposed to agitation associated with dementia, full stop, we have associated with dementia due to Alzheimer's disease. I believe the FDA's stance on this is that because different dementias have different underlying pathologies, perhaps different underlying neuropharmacology, that they are not permitting sort of cross-disease indications for these behavioral syndromes. So brexpiprazole works at serotonin and dopamine receptors. One of the nice things about this drug is that it avoids the anticholinergic and the antihistaminic and largely the anti-dopaminergic effects that I mentioned we try to stay away from when dealing with these drugs. It's a very similar drug to another one called aripiprazole that is also in the antipsychotic class of drugs. And you can see with this drug, so at about 8 weeks or so, we see a separation from placebo in its effectiveness in reducing agitation overall, as well as the global quality of life due to agitation. And you'll see that, yes, there is this separation from placebo, but it is a relatively small but real separation. So the effect size is not huge, but it was approved on the basis that it is beneficial when compared versus placebo. Suvorexant is a medicine that is an orexin receptor antagonist. So orexin receptors are located in various sites in the brain, and what they seem to do is, when stimulated, modulate and sort of coordinate multiple alertness encouraging activities. So things like attention and concentration. Perhaps they also reduce somnolence, increasing activities in the brain. But suvorexant has been approved by the FDA for insomnia in patients with mild to moderate Alzheimer's disease. So you can see, and again, this is a relatively small effect, but I think large enough to be clinically important, that total sleep time in the first, middle, and last thirds of the sleep period through the night is increased. They are increased with suvorexant. And then wake after sleep onset. So this is in people who have fallen asleep and then are waking up either early in the night, in the middle period, or in the last period of the night. We don't really see much benefit for suvorexant in that first third of the night, but we do start to see pretty substantial benefit in the last third of the night. And this is really important, particularly for caregivers, but also for patients themselves. Caregivers often are on alert throughout the day and night because patients have poor sleep. And in particular, they tend to sort of get up and get busy kind of early. And so enabling someone to stay in bed for that last third of the night is important. We wish that we had a drug that had a bigger effect, but this is at least something substantial. And it's a pretty well tolerated drug also. You can see that the rate of somnolence in individuals on suvorexant was a little bit higher than placebo, 4.2 versus 1.4%. But otherwise, in terms of side effects, it's really quite well tolerated. And so now a drug that's approved not for dementia specifically, but for a phenomenon that happens frequently in dementia, pseudobulbar affect. So dextromethorphan combined with quinidine does show benefit in reducing uncontrollable, disproportionate laughing or crying, also known as pseudobulbar affect. So in the FDA's definition, this occurs suddenly, frequently, and is involuntary. And so they have approved dextromethorphan quinidine for this purpose. In my practice, I usually see that people sort of either respond or don't. And if they do respond, you tend to see that response within 2 to 4 weeks. We see pseudobulbar affect pretty commonly in people who have subcortical lesions. So it's pretty common in multiple sclerosis, in cerebrovascular disease, in ALS or Lou Gehrig's disease. If you actually sort of study people with Alzheimer's disease, you'll find a higher rate of this than we would expect from that bilateral subcortical lesion kind of construction of pseudobulbar affect. So in our clinic, we did a brief study, and we ended up with about 28% of our individuals with Alzheimer's disease who, when we asked the caregiver and or the patient, did have pseudobulbar affect. We can also see pseudobulbar affect in depression in individuals who have dementia. Pimavanserin is another drug that's not approved specifically for dementia, but it is approved for hallucinations and delusions in Parkinson's disease. So people with Parkinson's disease have about a 50% lifetime prevalence of hallucinations, and cognitive impairment, including dementia, is the most important risk factor among Parkinson's disease patients. So we see hallucinations and delusions very frequently in people with Parkinson's disease-related dementia. Pimavanserin is a very clean drug, also working on the serotonin 2A receptor. And we can usually see a benefit from pimavanserin in about a month, which is certainly longer than patients and caregivers hope for. And it's very important to let people know that we're not going to see an effect in a week. We're not going to see an effect in 2 weeks, but we will hope to see an effect in about a month. So they got to finish that first bottle. And that's what I usually say to my patients, that you got to get through at least a bottle of this unless you're having significant side effects to see if it's going to work. There continues to be, though, even after day 29, continued separation from placebo. So if you can get people to stay on it for 3 months, I think that's really the best way to tell if they're going to have a good response. And so in this way, it is a little bit more like what we expect with an antidepressant medicine, perhaps because it's operating on serotonin receptors, which most of the antidepressants do, where you have this 8 to 12 week period that you need to wait before you see benefit. As opposed to antipsychotics, the traditional antipsychotics, usually we would be seeing benefit within days or weeks, or days or a couple of weeks. And so this I think, is important to point out that we're not going to expect the rate of response in terms of the time to response that we would see with antipsychotics traditionally. Pimavanserin is not approved for psychotic symptoms other than in Parkinson's disease. So in the community and in the clinic, it gets used sometimes for treating psychotic symptoms due to other dementia or the dementing disorders, particularly Lewy body disease, but also Alzheimer's disease. It's not approved to treat agitation, aggression. It's approved specifically for hallucinations and delusions. And although it does not cause Parkinsonism because it does not block dopamine receptors, it's not completely benign, and it has side effects that you might not necessarily associate with an antipsychotic. So lower extremity edema is the most common one that I've seen, and that's also what was seen in the studies most commonly. Nausea is also a common side effect. The older antipsychotics were actually very good at reducing nausea, and so I've even had in my clinic patients come in whose doctors told them that they couldn't be getting nausea from this drug because the class of drugs it's in doesn't cause nausea, but it's a different mechanism of action from the typical antipsychotics. And then confusion, as can happen with any CNS drug in someone with dementia. So uses that are not approved by the FDA are cognitive medications, which are approved for enhancing cognition or slowing cognitive decline in individuals with dementia, also can have some behavioral effects. And so in this next set of slides, green are data that we have supporting the use for that particular indication or that particular phenomenon, and red will be where we have data that does not support the use, data that says that the medicine isn't useful. So the cholinesterase inhibitors, donepezil, rivastigmine, galantamine, they have variably been shown to help with apathy in Alzheimer's disease, very common problem, to reduce aggression and also to reduce aberrant motor behavior. So that can be things like picking, pacing, and so forth. And memantine, glutamate antagonist, that's used for or indicated for moderate to severe Alzheimer's disease dementia, that also used in other dementias, has been associated with reduced agitation, lower levels of irritability, and better performance overall on the neuropsychiatric inventory, which is kind of a catch-all evaluation of behavioral symptoms in people with dementia. Antidepressants are looked at very frequently for treating behavioral symptoms in dementia. They tend to be relatively benign. They're tolerated pretty well for the most part. And there's sort of a mixed picture with these drugs. First of all, interestingly, although they have the same putative mechanism of action, they seem to have differential effects on specific behavioral syndromes in dementia. So sertraline has been shown to reduce agitation and actually to improve cognition. And one thing you'll see across these drugs is that in general, antidepressants seem to be beneficial for reducing agitation. Probably the best study, the most rigorous study of antidepressants for behavioral symptoms in dementia was a study of citalopram for agitation in folks with Alzheimer type dementia. So the study was mixed in that they did find beneficial effects on agitation at a 30 milligram dose, a little bit higher than the typical dose. But at that dose, they also saw a small worsening of cognition versus placebo and prolongation of the QT interval on the EKG, which is a predisposition to get a potentially fatal arrhythmia. So people have, I think, started moving away from the use of citalopram because at the dose where it's effective, it also has these negative effects. Citalopram has also been shown to be beneficial across FTD behavior. So when evaluated sort of en masse FTD behaviors such as compulsiveness, apathy, lack of empathy. There's a benefit with use of citalopram, and I think the experts in this area generally feel that it's most SSRIs in helping with frontotemporal dementia behaviors. Fluoxetine has some benefit for pseudobulbar affect. Trazodone can be beneficial for insomnia. It's really the one drug, I think, still that has two controlled studies looking at its use in frontotemporal dementia behaviors, and those studies did show benefit versus placebo. And trazodone can also reduce agitation in Alzheimer-type dementia. Bupropion has not proved to be beneficial for apathy. It was studied because it increases dopaminergic and noradrenergic activity in the brain, but didn't really seem to have much effect on apathy. Mirtazapine, somewhat sedating antidepressant, often used to treat insomnia, I would say relatively effective with treating insomnia, did not seem to have much benefit when used for agitation or for its primary indication, depression, when applied in people with dementia. Sertraline has mixed effects when used for depression in dementia. So the antipsychotic class of medicines, they actually are reasonably effective in agitation and aggression and in psychosis. Relatively recent network analysis showed that aripiprazole may have the best overall effects on improving behavioral or improving agitation and aggression in among the antipsychotics. It is, I would say, not well tolerated, probably moderately tolerated among individuals with dementia. As I mentioned, it is very close in structure to brexpiprazole, which is approved for use in dementia. However, it is not approved, aripiprazole. Brexpiprazole is still under patent and so considerably more costly than aripiprazole. And I think that has led a lot of people to use aripiprazole on the strength of this data, as well as the fact that it's similar to a medicine that's approved by the FDA. Now, we generally use antipsychotics as kind of a last resort. And the reason is that there are some significant liabilities with using antipsychotics. There are increased risks with antipsychotics of sudden death and of cerebrovascular accidents or strokes. So with antipsychotics, the risk for sudden death goes from about 1% to about 3.5%. So double to triple the risk over a year. So that's not a huge absolute increase, but proportionally it's quite an increase. And of course, if you spread that across the dementia population, those are huge numbers, right? 2% of the dementia population that may be at increased risk for a stroke or sudden death. Tardive dyskinesia is a movement phenomenon that's caused by chronic blockade of dopamine receptors. So we would expect this only with the dopamine blocking antipsychotics, which is pretty much what we see. But it is a permanent effect if it's not picked up in time. And often, even if it is picked up right away, we aren't able to get rid of it even after stopping the drug. And then there are very important reversible effects. So metabolically, these drugs as a class tend to cause increased blood sugars, increased weight, increased cholesterol. They can cause extrapyramidal symptoms, which again are caused by blockade of dopamine receptors. So this can be Parkinsonian type movement, phenomenon called akathisia, which is a very, very uncomfortable motor restlessness, sometimes so much restlessness that the individual actually has to keep moving. They're compelled to keep walking, moving around. They just cannot sit still. And then falling is also common. And as you can see from this graph on the right, when you look at all-cause hospitalization for people who get started on an antipsychotic within 30 days compared to the general dementia with agitation population. If you have dementia and agitation or aggression, you have about a 3% chance of ending up in the hospital in any 30-day period. If you get started on an antipsychotic, that risk goes to 11% of being hospitalized within 30 days after starting the antipsychotic. And then the risk for any serious event goes up from 4%, 4.5% to almost 14%. So these drugs need to be taken very, very seriously. In the past, we used anticonvulsants quite a bit, particularly divalproex or Depakote and carbamazepine or Tegretol. And they may have their place still. They're somewhat difficult drugs to use because they also have a fair amount of toxicity, although their toxicities are a little bit more specific than the antipsychotics. Sedatives and anxiolytics. Again, sedatives we try and stay away from because of the risk for sedation, for the risk for imbalance and ataxia. And then benzodiazepines in particular have dependence and withdrawal risks. Buspirone is a non-sedating, putatively I should say, non-sedating anti-anxiety drug where there's not a strong amount of data in use for anxiety or anything else in individuals with dementia. Prazosin, which is primarily used for benign prostatic hypertrophy and can also be used to reduce blood pressure. So it is an alpha-2 agonist, has shown some benefit for agitation and aggression. I mentioned earlier that dextromethorphan and quinidine is used for pseudobulbar affect. It has also been studied for agitation and aggression in Alzheimer type dementia and does so show some benefit in comparison with placebo. Relatively well-tolerated drug, a little bit difficult to get insurance to cover it for this purpose, but may be of benefit, particularly in the more medically fragile population. And then pimavanserin, which I mentioned before, has been used or is approved for the treatment of Parkinson's related hallucinations and delusions, has been tested for psychosis in dementia. And while the results were positive, the FDA declined to approve pimavanserin for the use in psychosis in dementia because the FDA felt that, as I mentioned before, lumping dementias into one category was not a useful way to approve a drug. And so they told the makers of pimavanserin that they had to demonstrate its benefit in one dementia population in order to get it approved. I'm going to take a break right here and just ask if there are any questions to this point. And if not, then I will go ahead with sort of the recommendations about what to do on the basis of this data.
Sure, yeah, I can ask maybe a couple of questions from the chat since you're taking a break.
Okay.
So somebody asked, do you see a reduction in formed visual hallucinations with rivastigmine versus other cognitive enhancers?
Yeah, so a reduction in formed visual hallucinations with rivastigmine versus other cognitive enhancers. So yes, we do see that. So rivastigmine is specifically indicated both for Alzheimer type dementia, mild, moderate, and severe, and it's approved for Parkinson's disease dementia. And very frequently in Parkinson's disease dementia, as I mentioned earlier, we get hallucinations, and those hallucinations are typically well-formed. I would say that my experience has been that any of the cholinesterase inhibitors are able to reduce the frequency of formed hallucinations. I tend to see better effects in the Parkinson patient with formed hallucinations versus, say, an individual with Alzheimer's disease. But I have had at least one patient with cortical blindness who was experiencing hallucinations who responded to a cholinesterase inhibitor, although I have to admit I can't remember which one it was.
All right, thanks. Yeah, I think you can go ahead. I'll save the rest of the questions for after.
Okay. So as I mentioned before, the guidelines and practices are a little bit difficult to follow because there's a lot of contradiction, even within a single medication about the benefits for treating these syndromes. The risk-benefit analysis is individualized. Remember that safety is always first, and the kinds of behaviors that are driving a reduction in safety in one person may be very different from those in another. The suicidally depressed individual, they are at high risk. So is the patient who is agitated and wandering at night, very high risk, right? And so there's no way to really sort of say, you have to treat this kind of behavior, and this other behavior, you can leave it be. One important thing to point out is that non-pharmacologic therapies typically are low burden and have mixed benefit, and I'll do more of a summary of that toward the end. But generally, non-pharmacologic therapies are not going to hurt the individual that you're trying them on. So the benefit to burden ratio is somewhere between 1 to 1 and infinite, right? Because some of them have no burden, whereas all the medications will have a benefit to burden ratio that is definitely not infinite. So I've sort of split this up into interventions that have high, medium, and low benefit to burden ratio. So among the high benefit to burden ratio are the dementia drugs, the cognitive enhancers, cholinesterase inhibitors, and memantine for treatment of aggression and agitation. And the reason I put these here is not because they are so super effective, but because the impact on quality of life of the behaviors is very high. And because most of the time we are going to want our patient on one of these drugs anyway. And so we're not additionally burdening the patient the way that we would if we're starting a cognitive enhancer and another medicine on top of that. So these are high benefit to burden, and also high benefit to burden are antidepressants for similar reasons, that they tend to be well tolerated. Their efficacy is reasonable when you compare them to the other drugs that we use for treating behavioral symptoms. And aggression and agitation usually have severe impact on quality of life. In the kind of medium benefit to burden ratio, antidepressants for depression, they are low burden, as I mentioned. Their efficacy is not so great, but we don't have a lot of treatments for depression outside of the antidepressants. And so we use them, and I would say that if you aren't able to get someone out of depression, that you should, go on to a different medicine, perhaps with a different quality or a different mechanism of action. Also in this category, mild or medium benefit to burden antidepressants or dextromethorphan for pseudobulbar affect. So the specific antidepressant that seemed to show benefit was fluoxetine. Pseudobulbar affect has mild to moderate impact on quality of life. Many individuals decline treatment for pseudobulbar affect because they don't want to start a medicine for something that is not affecting quality of life that much. But there are some people for whom this is a pretty important component. Dextromethorphan is pretty effective for pseudobulbar affect and also pretty well tolerated. In individuals with depressive symptoms without the actual syndrome of major depressive disorder, usually cognitive stimulation and massage or touch therapy, so these are obviously non-pharmacologic treatments, appear to be superior overall to medications. If someone does meet criteria for major depressive disorder, then medication is the way to go because these non-pharmacologic therapies don't seem to provide a substantial amount of benefit. Now, this is in someone who has dementia, and so I would say dementia where their remaining cognitive status makes them unable to participate in psychotherapy. People with mild cognitive impairment and even some with mild dementia may respond to psychotherapy, particularly cognitive, behavioral, and interpersonal therapies. Also in the medium benefit to burden ratio, antipsychotics for aggression agitation. Of course, these are high burden drugs, as I mentioned, and I only use them really if there's a physical risk to the patient or others, because they have such a high burden in terms of risk for the patient. And while effective, they do really increase the risk of significant decline in quality of life, despite the fact that these behaviors are also affecting quality of life. And then prazosin for aggression and agitation. Moderately effective, fairly low burden, at least according to the studies, and being employed for a high quality of life impact behavior. So some attempts have been made to put all of this into a comprehensive framework. This, I thought, was a very good network meta-analysis of treatments for aggression and agitation. And this graph in concentric circles, it shows the specific behavior, so verbal, physical agitation, verbal and physical aggression, combined agitation, aggression on the outside. And then each sector of the graph shows a different intervention. So, we'll go on to the next one. So this included 163 articles. And my summation of this is that, in general, antipsychotics, shown in these sectors down at the kind of 7 o'clock or so position, antipsychotics are most useful for verbal agitation. So roughly where you see green, that's efficacy 75% or greater. Where you see kind of yellowish green, that's in the 50% range. And where you see oranges and yellows, you're usually talking about 30% or less efficacy based on this network analysis. Atypical antipsychotics, which are right here, have kind of a moderate benefit for agitation and aggression. And there are non-pharmacologic treatments that seem to be generally effective. So massage therapy, this sector is mostly green with sort of a yellowish green for verbal agitation. Outdoor activities, mostly green, not as effective for physical agitation, but reasonably effective for verbal agitation. And then a change in the person's daily activities. You could see a mostly green sector with ineffectiveness for verbal agitation. Other general principles, physical agitation and physical aggression are generally kind of difficult to treat. And education and support, at least based on this meta-analysis, although I think that they are useful for the patient and for the caregiver, they are not that useful in actually reducing the behaviors, which is what this meta-analysis looked at. Well, what does the future look like? We can see it's kind of a mixed picture currently, and we certainly hope for better treatments. So pimavanserin, that's that medicine that's useful for or approved for treating Parkinson's-related hallucinations and delusions. I suspect that they will try again to get approval from the FDA, perhaps for the treatment of agitation and aggression in Alzheimer dementia, or for hallucinations and psychosis in Alzheimer type dementia. The dextromethorphan-quinidine, they have come up with a deuterated form. So this is using heavy hydrogen in their dextromethorphan molecule. And this seems to prolong the effect of the medicine in the body. And so they are testing that now for pseudobulbar affect and for agitation. Lumateperone, this is an antipsychotic that is currently on the market, and people think that it may be useful for treatment of dementia because its pharmacology is favorable. So it looks in some ways sort of like aripiprazole and brexpiprazole, with additional effects on glutamate receptors. There's a combination of bupropion, which is an antidepressant that's already on the market and has dopaminergic and noradrenergic qualities, combining that with dextromethorphan for agitation in dementia. And then nabilone, which is a cannabinoid 1 and 2 partial agonist, may be beneficial for the treatment of agitation as well. And that was actually on that wheel toward the left side of the wheel, really high effectiveness for combined agitation and aggression. So this is a pretty tough landscape to navigate because there are intense pressures to treat from primary care doctors, from care partners of patients, from patients themselves. Behavioral syndromes usually have a larger effect on quality of life than cognitive symptoms do. And so people really want to get rid of these symptoms. There are not a lot of robustly demonstrated treatments. So we have studies, many of which are promising, but very few of which are sort of slam dunks saying this is what you do in this situation. Our most robust treatments, which are the antipsychotics, are risky treatments. These are treatments that we're not just talking about, a little weight gain or drowsiness. We're talking about actually increasing the rate of death or stroke. And the data are not great on these treatments. There are huge downstream effects of treating these patients on their quality of life and on the costs of caring for them. In addition to decreased mobility and loss of continence, behavioral symptoms are one of the primary reasons for residential placement, as well as perhaps the main reason for hospitalization of individuals with dementia. Caregiver education, although it is not supported in a meta-analysis as being effective for stopping behaviors, can be very helpful in getting caregivers lower a degree of anxiety and impairment of quality of life because these behaviors are happening. Many of these behaviors can feel very personal. When someone is aggressive towards you, that feels personal. When someone accuses you of stealing their stuff, that feels very personal. And so helping caregivers to understand how the disease state interacts with a person's environment to produce these behaviors can be very, very helpful for them. And things that help the caregiver actually are very helpful to the patient as well. Also, educating caregivers can give us insight into what's going on with the patient. As I mentioned, the types of behaviors that show up are very different across disease processes. And there are times when the caregiver's report about a behavioral symptom has helped to nail the diagnosis. And then helping them with their caregiving skills. So a big part of that is their self-care, but another big part of it is training them and helping them to learn about some of these environmental interventions that can help, but particularly also the non-pharmacologic activity and interventions, getting them outside, getting them to exercise, and so forth, which can actually reduce these behaviors. So environmentally, aromatherapy can be helpful. Lavender and lemon balm specifically for agitation, wandering, and aggression. Music therapy and massage or touch therapy also for agitation and aggression. And physical exercise and outdoor activities are very helpful. And remember also to think about physical symptoms that an individual is going through. Herbal medicines can be useful. I mentioned ginkgo biloba. Yokukan-san is also helpful for these specific behavioral syndromes. And I think that is, yes, that is the end of my slideshow. And so I'm happy to take questions.
Well, thanks, Dr. Wint. That was a really informative lecture. I think I learned a lot from that. I think a kind of overarching question that I was just thinking about as I'm thinking about my own clinical practice, is I tend to get questions from patients a lot about medications. And as a non-prescriber, I'm kind of always in this position of, well, okay, I need to decide what is appropriate for me to tell them based on my knowledge of the science
Mhm.
without actually having the proper training in psychopharmacology. So from your perspective, I'm just curious of where you see neuropsychologists, like what should be our role in discussing medications like this with patients and their families.
Well, I think it would be fair to say that there are very few medicines that are approved for use in these behavioral syndromes, that there are non-medication interventions that you can actually do yourself, care partner or patient, that can help to reduce these and have been shown to be effective in that in the long term, the non-medication interventions are likely to be more or are likely to be safer and often more effective than behaviors at the same or than medicines. At the same time, when we're talking about a behavior that is imminently risky, I think in those situations, even though we still have the same truths that non-pharmacologic treatments are safer, that that's both in the short term and the long term, and that the pharmacology has not shown really robust effects. For this moment, we probably will need to go with medication because when it works faster. And going with a medication does not preclude using those non-pharmacologic treatments, right? Often it takes a few different things going on at the same time to help the patient to feel and function better. And so it's yes, and so we, in some cases, it's, well, yes, those medicines are appropriate if these non-pharmacologic interventions don't work. Sometimes it's, yes, we need a medicine now because it works faster, and we should also be doing these non-pharmacologic things as well.
Yeah, that just makes me think of like a lot of psychiatric treatment, right? Is that
Yeah.
pharmacologic option plus a behavioral, cognitive, emotional kind of non-pharmacologic intervention. The combination of the two is very effective. And I love the individualized approach that you were taking when you were speaking about that. I have a couple of specific questions from some audience members. So maybe two of these kind of go together. One person asked, I have a lot of patients who are prescribed quetiapine for insomnia. Do you have any thoughts on this? And then there's another question specifically about I've seen patients prescribed quetiapine on an as needed basis for agitation. Why would these be preferred over antidepressants? I wonder if you can take those
Yeah.
together or I can separate them.
So while I definitely want to say that treatment is individualized, and so it's not necessarily wrong. Quetiapine is in the class of antipsychotic medications. And, I have my own thoughts about why antipsychotic medications are dangerous. One thing that some may have noticed in the graph is that typical or traditional antipsychotics appear to be more dangerous than the atypical or newer antipsychotics. I suspect that dopamine blockade has something to do with it. And therefore, medicine with low dopamine blockade may not have those same liabilities. And quetiapine is one of those medicines with low or essentially no dopamine blockade as part of its mechanism of action. So maybe it's safer. That's hard to demonstrate, but if you have someone with insomnia, I would say that we have other options. For example, trazodone, mirtazapine, maybe even one of the herbal medicines, sleep training, setting up the sleep environment that have lower risk, at least from what we know of that class of antipsychotics, than an antipsychotic like quetiapine. And so my preference would be to not use quetiapine for insomnia, but that may be where you end up. You have to think also how much of the insomnia might be due to, let's say, depression or mania-like syndrome, or even psychosis thoughts or hallucinations, in which case an antipsychotic medicine is an appropriate medicine. So it depends a lot on the individual case. But if it's sort of primary insomnia, I would try to avoid an antipsychotic, as long as possible. The use of quetiapine as needed for, I guess, for agitation or for insomnia or what?
Yeah, there was one question specifically about treating with it for insomnia, and then another for using it as needed for treatment of agitation.
Yeah. So I can't think of any studies offhand using it as needed for agitation and aggression. Studies using it routinely for agitation and aggression haven't panned out all that well for quetiapine. So there may be an effect for agitation, but it may also be simply quetiapine sedating effects help someone to either fall asleep or to be so drowsy that they're no longer verbally agitated or aggressive, or they're still verbally aggressive, but they can't throw anything because they're so sedated. It's kind of hard sometimes, and you really have to sort of pin down care partners with how exactly does quetiapine work. Are they calmer and more functional, or are they calmer because they're almost asleep? Again, I wouldn't say that there's never an appropriate place for it. And I've had situations where I'm using quetiapine as needed, but usually that's as a backup to something else that's preventing, hopefully, or trying to prevent agitation and aggression, or at least reduce it, because it's a general rule that it's easier to reduce the frequency of a behavioral event occurring than it is to address the behavioral event when it occurs. That space between when it starts and when the medicine kicks in, especially if it's a space that is appropriate for an antipsychotic, where someone's doing something dangerous, that's a space in which someone could get hurt. So I would say as an adjunct, PRN medicines, but somebody really ought to be on something to keep the behaviors from happening.
Great. I think maybe we have time for one last question, and this might be because you had mentioned that one drug that was a cannabinoid agonist, I think you said. And so somebody asked if there's any research specifically on like CBD. I'm guessing they're asking like over-the-counter CBD products in helping behavioral symptoms.
Yeah, I haven't seen any research yet, although lots of anecdotal reports from care partners primarily. And I'm getting sort of mixed reports, but it's very hard to know how to assess those because, literally every single person who has a report is likely on a different formulation of the cannabinoid product. I'm almost certain that someone will find a beneficial effect, but doing a study like that is hard. The companies that make marijuana that's sold over the counter aren't typically medical manufacturers, and typically are not well set up to help an investigator perform a study, especially a placebo-controlled study, if that's what you want to do.
That makes sense. Well, I think that brings us to time. Again, thank you so much, Dr. Wint. That was a great, great talk. I am going to direct everyone's attention just to our next talk, which will be on March 18th at 1 o'clock Eastern Time, where we'll learn about neuropsychology of schizophrenia with Dr. Jimmy Choi. All right. Thank you, everybody.
Thank you very much.